Hello and welcome. This is Kristen Honshorst, Project Lead on the Women's Heart and Brain Health Research Initiative with Heart and Stroke. A couple of housekeeping items before we begin. If you've successfully downloaded the GoToWebinar software, you have two options for audio. The first is to listen with your computer speakers. Make sure they're switched on and that the volume's high enough. The second option is to listen through your phone with the number and access code provided below and dial your unique audio PIN that will show up in your webinar dashboard when you log in. If you have questions or need help, please use the questions feature in the webinar dashboard. Questions will be addressed at the end of the webinar. We are recording this session, and the recording will be uploaded to the Heart and Stroke YouTube channel following the presentation. The link to the recording will also be sent to all registrants after the webinar. An optional evaluation survey will be sent to everyone following the webinar. Information from the survey will help inform future learning sessions like this one, and all information is kept confidential. We will email you a link to the survey along with the link to access the recording for the session. Now, before diving into today's program, I want to acknowledge that I'm a settler on Algonquin land. Today, we're joined by over 200 people from coast to coast to coast. I encourage you to reflect on the land where you are all located and what being there means for you and for those that were there before you. Equity matters to Heart and Stroke. It's a pillar guiding our work, and it's a pillar that we are working through to address the inequitable burden of heart disease and stroke borne by women, including Indigenous women and Indigenous gender diverse peoples. Today, we'll cover a bit about how Heart and Stroke is working to address inequities in women's heart and brain health through our research network. We'll also hear from network member Dr. Bernice Downey. Now, due to unforeseen circumstances, unfortunately, the Native Women's Association of Canada was unable to present today at the last minute, but we have recorded their presentation and we'll send the link to that recording to everyone registered for today's session. Finally, we'll also have time for some questions. Today's session is made possible through our Advancing Women's Heart and Brain Health Research Network. The Research Network is part of a 5-year contribution agreement with Health Canada to advance research on women's heart and brain health. To date, we've funded 15 researchers across Canada. Additionally, convening people with lived experience, researchers, practitioners, and policy experts as part of this network represents Heart and Stroke's commitment to building awareness, facilitating access to information, and improving technical capacity and professional development for the next generation of investigators around women's heart and brain health. We're proud that our membership is in excess of 150 members, and it's open. At the end of today's session, I've included my email address for anyone who is interested in joining our research network. Now, without further delay, I'm pleased to introduce Dr. Bernice Downey. Dr. Downey is a woman of Ojibwe and Celtic heritage, a mother and a grandmother. She's a medical anthropologist with research interests in health, health literacy, and Indigenous traditional knowledge and health research systems reform for Indigenous populations. She's cross-appointed to the School of Nursing and Department of Psychiatry and Behavioral Neurosciences and is the Indigenous Health Lead for the Faculty of Health Science at McMaster University. Recently, she was awarded the Heart and Stroke Foundation Canadian Institutes of Health Research Early Career Chair in Indigenous Women's Heart and Brain Health. She is also a lifelong advocate in the work towards addressing the serious health inequities among Indigenous populations in Canada. Dr. Downey, over to you.
Thank you very much, Kirsten. I'd like to acknowledge the Indigenous people of the territory where we reside here at McMaster University, the Haudenosaunee and Anishinaabe people, who are guided by the Dish with One Spoon Wampum Agreement. I also have with me my colleague on this project is Dana Hart, who's a research assistant, and is working closely with me on this project. So I'd like to also thank you for the opportunity to participate in the webinar, and actually to the Heart and Stroke Foundation and CIHR in acknowledgement of the funding and as a recipient of one of the early career awards. So welcome everybody. Ani, hello, bonjour. Thank you for taking the time to participate and to hear a little bit more about this project. We are in early days. As Kirsten mentioned, we received the award in August. We are currently in the research ethics application phase, and we have done some early community partnership engagement, which I'll talk a bit more about. But you can see on the screen there, the title of the project is Mending Broken Hearts, Odayimman Hart Project. The Broken Hearts piece is linked to understanding the connection to what Indigenous women have experienced through the residential school system and the intergenerational trauma that has occurred. So it's really kind of looking at the whole, all of the sociocultural factors related to heart health, heart illness for Indigenous women. So I just wanted to comment on that's how I came about the title. So next slide, please. So again, this is the funder slide and speaks to the number of funding agencies that went into the project. Now you'll see the last bullet mention of the Social Science and Humanities Research Council, which we just became aware of a separate piece of funding that's linked to this project, and I'll talk about that a little bit later as well. Next slide, please. So the way we laid out this presentation is talk a little bit about the team involved. You can see a list there, a little bit of information about Indigenous women and heart health, an overview of the project, some conversation around the research tools and methodologies piece that we're working on, and then a little bit about the outcomes and opportunities. Next slide. So there's a smiling picture of the two of us here.
Oh no, I'm gone.
Oh, okay. Dana's disappeared. Maybe it'll pop up. Yeah, so as mentioned in the introduction, I'm the principal investigator. I'm a medical anthropologist, and I was also started out my career as a nurse, as a registered nurse. So my education has been a laddered process. Went on to get an undergraduate in nursing. And then over the years in my engagement at the national level in health policy, I was the executive director of the Aboriginal Nurses Association, and I was also the chief executive officer of the National Aboriginal Health Organization. And through those files, those roles, became clear to me, I was making a link between how we were engaging with Indigenous populations, and I focused on health literacy. I've been sitting on the Institute Advisory Board of the CIHR Institute of Aboriginal Health, and there's lots of conversation about knowledge translation. The cadres, as they were known at that time, were starting up. Was how we're going to roll out, the research related to Indigenous peoples in ways that is fitting for communities. All of those kind of important topics, and health researchers that have been kind of paving the way for Indigenous health. And so at that time, to me, it felt like one of the missing links was how we were sharing health information with Indigenous peoples, and that's what kind of brought me back to graduate school. So I did a master's in cultural brokering here at McMaster, and then determined I would do PhD. And I was fortunate enough, and this is the whole cardiovascular disease link, I was fortunate enough to link with Dr. Janet Smiley, who is a Métis physician and health researcher, and she heads up the Well Living House at St. Michael's Hospital in Toronto, which is a participatory action research center for women, families, children's health. And she was engaged in a larger project with Australia and New Zealand looking at health literacy. And the overall goal was to improve compliance of cardiovascular disease medications for Indigenous populations with a similar goal that I'll be talking about of training healthcare providers so that they could encourage patients through the use of an app that would provide sociocultural information and help make that bridge in the health literacy realm. So I was the only medical anthropologist on the team, but so it provided me a way to talk to clients about, I was interested in knowing that if they had their Indigenous language, if there was some fluency there, and they also had access to their teachings from elders, community members, or others about a personal responsibility to health and well-being, was this in fact a culturally congruent process of health literacy? So it was challenging to develop that because the health literacy mode was very much about reading, writing, and arithmetic, if you will, making sure clients could read their medication bottles, understood health posters, and understood the information that their healthcare providers were giving them. So that's just a little bit of some of the background on this project, how I got there and how I got to be where I am today. So it's an early career award that I received in August. I'm very appreciative of the opportunity because it's going to help me expand my research from my doctorate where I developed a harmonized health literacy model, harmonizing both biomedical approaches to health literacy and Indigenous ways of knowing. So I'm going to let Dana Hart introduce herself a little bit. Sorry, themselves. Dana is teaching me all about political correctness with respect to identity, and I'm going to let her talk a little bit about that. Yeah, that.
Hi, everyone. My name's Dana Hart. I am a research assistant on this Odayimman Mending Broken Hearts project. I've been involved on the team since about August, September of 2018. I also I completed my undergraduate and master's degree in the anthropology department at McMaster as well. So my background is largely cultural, physical, and biomedical anthropology. And my background is that I'm from the Ontario area. I've moved many times, but my family roots are Mi'kmaq and settler in Newfoundland. Thank you all for coming today.
Great, thanks, Dana. So you can see on the slide there, our other three partners, we have their community logos. So on the first one on the left there is the Downey Aboriginal Health Center. So all three communities we engaged in initial community relationship building as part of the proposal development process. We do not have formal partnership agreements from all three yet, but once research ethics is approved, then we'll return to Downey and seek signing of a formal agreement. So Downey is the urban partner that we have here in Hamilton, and we have a very robust urban Indigenous population here of around 14,000 people. The middle logo that you see is Mississaugas of The Credit. They've just changed their formal name from New Credit to The Credit. First Nations, they're here not too far from McMaster University on a corner of the Six Nations Reserve. They have multiple communities in this area, but the community that we're working with is here closest to us. And then we have Six Nations of the Grand River Territory. Sorry, no, pardon me, that's another project. The other one is the Lake St. Martin First Nations, which is in Manitoba. And so all three of these communities will be working with us on this project. Next slide, please. Okay, so this is a little bit more background on this specific project. So as Kirsten spoke briefly about in her introduction to the webinar, the Heart and Stroke Foundation has advised generally that there is a gender gap between men and women in health promotion, diagnosis, treatment, and research, with women lagging behind in all areas. And for Indigenous women, this inequality is more severe because of many historic and present-day factors. In general, Indigenous peoples experience higher rates of extreme poverty, poor access to health, education, healthy food, and clean water as a result of the long-reaching impact of discriminatory government policies, including residential schools, that continue to impact Indigenous peoples across generations. Indigenous women experience a 53% higher mortality rate compared to non-Indigenous women in Canada, for example, of cardiovascular disease. Traditional roles of women as strong leaders in Indigenous societies have been altered due to cultural genocide, creating a rippled impact on family and community health and well-being. So this research program aims to work in partnership with those three Indigenous communities that I mentioned to learn from the knowledge and experiences of Indigenous elders, traditional practitioners, and Indigenous women. Organizational representatives who work with Indigenous women, educators, and researchers to develop an education program to train healthcare professionals who will be working with women. And so you can see that there's multiple stakeholders there that we're aiming to connect with so that we can get a broad base of feedback and information regarding Indigenous women's heart health and well-being. Next slide. So this speaks to the key objectives to the program. And so the primary goal of this proposed program of research then is to expand the body of knowledge regarding Indigenous women at risk of or living with cardiovascular disease and stroke. So we hope to understand how Indigenous knowledge or ways of knowing about well-being can assist Indigenous women with the self-management, increasing their personal agency overall of their cardiovascular disease or stroke illness. The Indigenous knowledge gathered will hopefully strengthen their cultural beliefs about the role of women within their families, communities, and nations, and contribute to their knowledge and ability to take charge and manage their own journeys of healing. A second important focus of the project is on healthcare professionals who work with Indigenous women. Healthcare professionals are generally not adequately prepared to work with Indigenous populations, and the way that they provide health information to Indigenous women is often not done in a way that is sensitive to Indigenous people's cultural needs. Health science curriculum is lacking in information that healthcare professionals need in their clinical practice to ensure that they are working with Indigenous populations in general in a culturally competent and safe way. It's expected that this research program will educate them about Indigenous and gender-based ways of working with women and about an Indigenous health literacy approach that may help them become more culturally competent. And finally, it's also expected that this research will contribute important information about the sociocultural variables linked to how Indigenous women experience heart illness that will positively inform policy development and clinical healthcare professional guidelines about this population group, and will contribute to the emerging Indigenous knowledge base that is being cultivated by Indigenous and non-Indigenous researchers across the country. Next, please. So you can see here a schematic of the general, on the left, the overall purpose of the project, and then you can see an outline of the key activities in year 1 and year 2. And so this was a schematic that we developed in our early engagement with communities so that they could see how the project is laid out. So basically, we use a community-based participatory research approach that's guided by the First Nations principles of OCAP, which is ownership, control, access, and possession. So CBPR begins with relationship building between community partners and the sharing of decision-making and ownership of the research. and in so doing aims to benefit the community and to address their identified needs and interests. And so that's such an important element. There were a couple of questions that were fielded to us ahead of the webinar, questions that folks have out there regarding Indigenous research methods, community engagement in particular. And so over the last 15 to 20 years, there's been such a significant element of Indigenous health or Indigenous research in general, reform to improve research engagement with Indigenous communities. So typically, in the past, where researchers have come into communities, with their own ideas and priorities around Indigenous research, with their own mainstream methodologies, and essentially non-Indigenous participants from communities have been passive partners in this process. And so, with the input from many Indigenous scholars across the country and stakeholder organizations and communities, we now have significant reform at the national level. So we have now in the Tri-Council Policy Statement 2, we have Chapter 9, which carefully lays out this aspect of community-based research. And so we now have non-Indigenous researchers and Indigenous researchers who have to comply with those standards. And so this is, helped communities engage and to begin to think about their own needs related to research. So I'll give you an example related to this project. So Indigenous peoples often, or communities or women, often don't think, well, we've got to figure out a solution for Indigenous women only. They see that generally, as I mentioned at the beginning, that heart health is a concern of communities for both men, women, and youth. And so often in that early engagement, what I would hear is, why are you just focusing on women? And so you have to explain the parameters of the project. But what we have determined is that in year one, that you'll see there in that blue balloon, that we will be having Indigenous community gatherings where people can tell us their stories about their heart health and contributing factors and so forth. And this will be open to the community. So it'll be Indigenous women and their families or elders or youth. And so they were pleased about that, and it was a way for them to feel that all of their perspectives could be included. So it's this harmonization process of both mainstream and Indigenous specific ways that's important to have the flexibility in the research process and guidelines to be able to work with communities in the way that they need. So you'll see there then, to gather data for our program, we'll start by interviewing Indigenous women with cardiovascular disease, as well as healthcare providers. We'll then measure the impact of our education program on cultural safety and self-efficacy, both before and after implementing it. So I'll just step back there to the interviews. Now, with 3 communities, so we had initially started out with 2 communities, and that was Mississaugas of the Credit and our urban community here. And then it was only after I was awarded the project, and this issue I'm going to speak to now is I think often experienced by Indigenous researchers. We're a very mobile group. My mom chose to raise us and our family here in Southern Ontario, and so I had limited connections to our family from both Dauphin River and Lake St. Martin. However, in keeping contact with my cousins and my aunties and so forth, been very much disturbed by a process that they've been engaged with, which was flooding of their home communities. Since 2011, 2012, forced evacuations of Lake St. Martin have resulted in people living in Winnipeg, and having high rates of stress and mortality, that compounded chronic illness that they're experiencing. And so in discussions with my family and so forth, I thought that I wanted to include them in the study. So I went back to the drawing board, and that resulted in a research application process to SSHRC. And we focused on how we share knowledge and information, but made a link to the key activities of the Heart Health Project. And so that's how we came to have 3 communities after the fact, but it's a very exciting aspect of it because, as I mentioned, working with your own communities, working with your own people, and advancing health and giving them tools where, that they themselves can work with in their communities is a very it's very close to my own heart, and so we're really looking forward to their engagement as well. So you'll see there that that third bubble of traditional healers and elders. So this speaks to the aspect of, what do we have in place now about knowledge sharing with elders and with knowledge holders, other knowledge holders, traditional healers in the community. We often don't include them. There's not a mechanism to include them in the healing relationship. What kind of messages do they have to share around wellness and how we can improve our own heart health? We're rapidly losing many of our elders who are holders of information, and so we're trying to attend to that both through individual interviewers and interviews and inclusion in our group processes, our community processes. Now, an important aspect that the SHIRK process allowed for us as well is we also want to include a knowledge holder apprentice in this work. And so while funding agencies encourage in the realm of capacity building within research, encouraged recruitment of graduate students, we also provided a parallel opportunity for knowledge holders who are apprentices in the community, who often are not funded, who are not connected to post-secondary institutions, but are themselves going through training and education with elders or traditional healers. We're creating that opportunity so that we can, it'll be interesting to see the comparison between their apprenticeship process and how they address these issues, and also with the graduate student that we'll have in Ontario. So that's an exciting part. So I'm kind of getting carried away here. So, and then of course the primary goal one of the primary goals is also to train non-Indigenous healthcare providers. So we'll be doing some pre and post testing to understand, where they are at. The information that we share, that we gathered from our data gathering activities, will be rolled up into and developed into a curricula. So we've hired an Indigenous curriculum specialist, and whose background has been very much about working with women, and that is Anita Harper. And so she'll be attending all the gatherings. I forgot to also mention among our team members, my apologies, is we also have Chief Maureen Chapman, who's from the Stolo First Nations out in the West. We have also Mike McGillian, who's the Director of Research here in the School of Nursing and closely affiliated with the Heart and Stroke Foundation. He also holds a chair. And Sandra Carroll, who's the Vice Dean here and here at the School of Nursing. And so we also are going to be recruiting a fluent language speaker from Lake St. Martin who will assist us in translating about key concepts at some of these data gathering. Okay, so I think that's it for this slide. Okay, so next slide, please. So this slide speaks, this is a picture just to demonstrate my research from my doctoral studies. And so the idea here is to demonstrate through this image of the medicine wheel how health literacy can be approached in a culturally relevant way. And so using the Ojibwe traditions and language and ways of knowing, you'll see there on the far right is in that yellow circle from the eastern direction represents harmonization or collaboration between elders, traditional healers, and healthcare providers. And as I mentioned earlier, typically elders are not included in this kind of work. And in the southern direction, in the green circle there, you'll see healthcare providers as cultural brokers. And so that's where I felt that, if we educated healthcare providers, gave them an opportunity to learn more about the culture, Indigenous ways of knowing, and so forth, that they would feel more prepared to work in collaboration with the client. However, what I encourage, what I often say to folks is you don't need to know everything there is to know about Indigenous knowledge. Rather, you just need to be able to make space for it. And so you'll see in the center is a blue circle that says Indigenous therapeutic relational space. So if a healthcare provider plays a brokering role and is familiar with the Indigenous peoples in their region or catchment area, then they can help create an access for Indigenous clients who wish to do this. And so you'll see the interrupted black line across the center of the circle that leads between the patient on the left or in the western direction and the elders, traditional healers, and healthcare providers. And that recognizes an equity in information and knowledge. So we acknowledge the patient themselves as having important knowledge to contribute in creating that relational space. And then finally, moving around the medicine wheel to the north, it's expected that they gain Nibwakawen or wisdom and empowerment and an increased sense of personal agency if they've been able to access both ways, and we've created a harmonization process. So that's how that kind of fits with what we're trying to do. Next slide, please. So this slide just speaks to the related literature review. And so as you can appreciate, there's very many aspects to this process. So an important part that we're trying to do and we're taking our time with in development of the research ethics application is delving deep into Indigenous methodology of knowledge exchange. So we're really looking into the whole storytelling aspect, how information is generated through that oral process as a community-driven process to share health information and to identify their role in wellness. We're also looking at areas of health coaching, training for the healthcare providers, of course, drawing on the work that's been done to date in cultural safety, and you can see there the other areas. Next slide. So this, I think, speaks to a little bit more about the community partnerships. And so we see, again, we emphasize this role, this important role of communities and within the realm of OCAP, seeing them as partners in the true sense, as leaders. We aspire to create an advisory council, so to help guide us in the work, and the activities themselves are also aimed to facilitate, explore Chikekadong, which is Ojibwe for knowledge sharing, hopefully towards achieving the Nibwakawen or wisdom that I talked about among community members, and to increase and facilitate access and understanding of Ojibwe values, traditions, and beliefs about wellness. So in the project that I talked about in terms of the flooding situation, in working with that particular community in Lake St. Martin, so the idea is not to just understand how that situation over the long term might have impacted their heart health, but also to support them with tools and ways to deal with the aftermath of that. Because going back to restructured communities that they're not familiar with, and after being away for such a long time, the story is not over yet. And so the goal is to also to support them in any way that we can through this project, as an example. Next slide. So this just speaks a little bit more to the storytelling process, again, utilizing Indigenous ways of knowing and trying to indigenize the research process. We will be drawing from both mainstream and Indigenous methodologies, but I'm very excited about this, and we hope to build on the work that's been used by COVACH, for example, Her work describes conversational methods. We also know that internationally, other Indigenous communities are drawing on storytelling. Indigenous Australian women have been working with a process called yarning, which is a conversational process of sharing stories and knowledge creation that's identified by community members. So it really is about, during this time, this post-TRC era, of reclaiming and celebrating our own Indigenous-based ways of doing things in terms of research and sharing knowledge. And so, this is an exciting part of the work with our community partners, who work in these ways, but often, but may not identify them as such. And so we look forward to learning from them as well. And of course, the language is closely connected. I don't have my Ojibwe Soto language. That was a choice that my mom made, that many Indigenous people made in a time when you would be, receive a lot of racism, discrimination for speaking your language. So it was a way to protect children so that they wouldn't be vulnerable to that. But I have many family members who are very fluent speakers and are engaged in this process to understand what these concepts mean. And so I look forward to see what will come of that. Next slide. So this slide speaks to one of the activities is bringing Indigenous women leaders together for a roundtable. And this speaks to understanding that not only has the historical impact of an assimilative government agenda and residential school intergenerational trauma, all of those things that, most people in mainstream are familiar with because of the media. But we also want to look at what are the knowledge, what are the strengths and resiliencies that Indigenous women hold, and learn from those from every sector, whether they're in politics or health or education, what have you. And so I have been building those relationships over the last year or so. And so I look forward to bringing people together so that we can also share that information in this process. Next slide. And so finally, the goal is in terms of health outcomes that we'll pay special attention to culture and gender to learn how Indigenous women understand their heart health and well-being and their current approaches to living a balanced life. We'll develop and test a culturally safe model of care delivery that will be used by healthcare practitioners to see if it increases Indigenous women's well-being, heart health, and relationships with their healthcare provider. And this model will also include both Indigenous and Western knowledge. And finally, we'll measure if the new model of care enables healthcare practitioners to form more reciprocal and trusting relationships with their Indigenous patients, and whether their patients feel that their concerns have been addressed. And finally, as the ultimate goal of this research is to improve health outcomes for Indigenous women, we must also think about future generations. And to do this, we'll be developing a workshop for Indigenous girls related to gender, positivity, well-being, cultural resiliency, and pride. And so this activity will also serve to build awareness with the communities regarding positive, culturally relevant health promotion and preventative lifestyles for young women and girls. So that's it. That's the last slide. So I'd like to turn it back to Kirsten, who's going to moderate questions or comments from our people online.
Thanks, Dr. Downey, and thanks, Dana. So we have had a couple of questions come in. The first being, I guess, going back to your project slide where you identified the different years of your work and what you were doing in each year. And the question is, are the traditional healers and elders that you're engaging with and involving women only?
No, they're not. And I guess, maybe there is an expectation that it would be women only, but, I think this kind of speaks to the Indigenous specific perspectives on feminism, women-centric ideas, and so forth. So we would see the input from both men and women elders as important to our sense of well-being. And that would provide a balanced approach to the way we achieve wellness. So we wouldn't make distinctions, that Indigenous elders who are women would be the only knowledge that we would draw from.
Okay. Another question. What can non-Indigenous allies do to support Indigenous women with health issues?
I'm sorry, could you repeat that?
Sure. What can non-Indigenous allies do to support Indigenous women with health issues or heart and brain health issues?
Oh, that's a great question. So, in my role as Indigenous Health Lead here at McMaster University Faculty of Health Science, we're often talking about how people can become health or education allies. And there's a lot of emerging discussion on this. Here in Ontario, some folks are now talking about the notion of Indigenous health or Indigenous apprentices. We can include a link to some materials that we're aware of here. But generally, the idea is that folks take upon themselves a reflexive exercise just to check as to what kinds of education do you need to assist Indigenous people in this work. And I guess it's depending on your role, but pretty much in any sector, whether it's policy and decision making or program development or working directly as a clinical practitioner with Indigenous women. So it's, what do you not know? And for most people, what I'm finding is they don't know a lot. And this speaks to how, as a society, we were all not privy to what was happening many, many years ago. That's been the benefit of the release of the Truth and Reconciliation Commission's report, is illuminating what did happen, and people are in this process now of wanting to do something, not sure how, and needing training and education. So here in Ontario, we're encouraging people to take part in the Ontario Indigenous Cultural Safety Training, which is based on the Sanyas model from out west. And we also have other online programs. So to engage in that training, kind of start with educating yourself, and then knowing a little bit more about what it takes to be an ally. So it's education of yourself, working with Indigenous peoples, not trying to have it all figured out before you do engage, but to aspire to the notion of nothing for us without us. And in terms of research, as I mentioned earlier, the Tri-Council Policy Statement 2 provides, in Chapter 9, provides very clear guidelines of how to engage with Indigenous peoples. I think the biggest concern is fear that somebody will say the wrong thing or offend a client, and so people generally just try to avoid. But I think, better to make a mistake than not to avoid, because there'll be enough Indigenous people around to tell you what your mistake is and to guide you to do something different. So I always just encourage people to to try to take that step. And if you start with education, it will help build your confidence to do so.
Thank you for that. As a follow-up to that question, what strategies or processes could you maybe recommend for establishing a relationship with Indigenous communities or establishing formal partnerships the way that you are in your work?
Okay, that's a very good question too. So as mentioned then, sorry, was that specific to research or just in general?
Yeah, it's to informing research. The person has indicated to inform research.
Okay, so as mentioned then, the Tri-Council Policy Statement 2, Chapter 9 has very specific guidelines that clearly lay out the need to include Indigenous peoples at the very beginning of the project. We now have research ethics boards in various universities that recognize the need to engage with communities at the very beginning of the research. We have experiences with communities. They want the opportunity to develop the research question. They might have nuance. They might have a general interest in the cardiovascular disease element, but they want, that they might be very nuanced in what they want to pursue as the actual question. So if you go through that with your academic team and then come to the community all prepared, that might be seen as a way of, not providing a culturally relevant way of inclusion. And it damages the relationship. So I think that's the key part, is thinking about the relational approach. So being a good partner, involving people from the beginning, asking them how they want to be included, what are their priorities, figuring out ways to build their capacity to develop a team where, funding flows through them to support them in their capacity. Indigenous communities are being flooded with requests for engagement, in all sectors. It's extremely challenging for them to be as responsive as they would like to be. So I think those are like some general guidelines. And of course, engaging in developing a research agreement that's relational focused, has protocols, an area of conflict resolution, a protocol that's stated. They have to go through their own processes. They're, getting approval from their band councils, or if they have a research committee. So those are the kinds of tools that help, nudge the process along.
Thank you. I've noticed that there are a couple of participants logged in who have their hands up in the webinar dashboard. I just want to remind everyone that if you have a question, please type it into the chat box or the question box. And I'm just going to give people a little bit of time to do that. I have one more question here that has already come in. Dr. Downey, I wonder if you can reflect on some of the determinants of health, and this is more of like a background question, but the determinants of health that are really informing your work sort of generally.
Well, that's another good question. So my position on the social determinants of health for Indigenous populations stems from my engagement with the WHO Commission on the Social Determinants of Health. So myself and another colleague here in Canada were the Canadian Indigenous participants that informed the work of our Canadian commissioners, who were the Honourable Monique Bégin, former health minister, and Stephen Lewis, who many of you are familiar for his work related to HIV. And so during that process, we engaged with Indigenous peoples across the world. And what we had hoped for was to really, influence reform around social determinants to understand the Indigenous perspective and move beyond just social exclusion, which was a way that was being put forward. The chief commissioner was Sir Michael Marmot from Britain, and this was the framework that was proposed with social exclusion. So I mention that because, that process was very much about advancing Indigenous rights-based consciousness and ways of knowing. And so what we ended up with, we had requested a chapter in the final report of the commission's work. What we ended up with was a text box. And I mean, we were inserted in different ways, but what we really emphasized was how land and self-determination were critically important social determinants of health for Indigenous peoples across the world. And so quite often, when the commission's work wrapped up and we came back to, as a Canadian reference group, to look at the uptake in Canada, the emphasis was really on most of the determinants that we're all familiar with in terms of education, poverty, and so forth. But there's been very little uptake around how land and self-determination is are important social determinants. And so, I advocate and try to create awareness around that. We also have the National Collaborating Centre for Aboriginal Health which is part of the Public Health Agency of Canada, who have released excellent documents around the social determinants and made these connections to language, Indigenous ways of knowing, land and treaty rights, and so forth. And so, without addressing those kinds of issues, it perpetuates the oppression and the lack of understanding of how our health is impacted by that socio-historical factors. So anyway, that's probably like another long presentation, but I hope that's illuminated my position a little bit.
Thank you. Yeah, I think that's really important. I think that's actually a great place to end. So I want to thank everybody for their questions. If people do have more questions that come in after the fact, please don't hesitate to send them in to me. And I just want to wrap up by saying again, as I started, that it was the last minute unfortunate circumstance that led to the Native Women's Association of Canada not being able to present today, but their recording of their presentation on their culturally relevant gender-based analysis will be distributed to everyone who registered for today's session. And if you have any questions or would like more information about our Women's Heart and Brain Health Research Network, please don't hesitate to reach out. I want to thank Dr. Downey and Dana for sharing your knowledge and for sharing the information about your project. We're really grateful, and we really look forward to seeing how it unfolds. So thank you.
Thanks very much, Kirsten. And I would also, if people have other questions or want to stay in touch regarding the project, we hope to have a website where you can access more information and perhaps an e-list at some point in time. But feel free to email me personally at McMaster University, and I think that's probably somewhere on this on the webinar information. So, Chi Miigwech, thank you very much for listening.
Thank you, everybody. Have a good rest of your day and week.